second. Good, we're recording. And I'm gonna start this music. It'll play for about a minute and then, Ryan, can you close the door? Hello, you are in the right place and we're excited to have you. My name is Allison Gilbreath and I am the Policy and Program Director at Voices for Virginia's Children, and welcome to Voices' second annual Racial Truth and Reconciliation Week, which is affiliated with the Racial Truth and Reconciliation Virginia Coalition. The mission of Voices is to champion public policies for children to improve the lives of Virginia's children. And 2020, Virginia's first Racial Truth and Reconciliation Week was founded in direct response to dual pandemics of COVID-19 and racism as a public health crisis. The mission of Voices is to champion public policies that improve the lives of Virginia's children, and that's what this campaign is all about. Voices takes this mission a step further, an acknowledgement of truth of communities to promote healing, reconciliation, and justice for children and families in the Commonwealth. Trauma-informed care and resilience individually acknowledges the disparate impact of trauma, but it is not an isolated response. When trauma is experienced collectively by communities, whether geographically, culturally, racially, or ethnically, we recognize this as a systemic issue. As advocates, we must change the systems that perpetuate trauma and further combat the root cause of cultural, racial, and historical traumas and long-term inequities of disparities derived from it. We must engage communities in championing their own solutions authentically and acknowledgement of truth to promote healing, reconciliation, and furthermore, collaboratively identify a solution that cures the root cause of the inequity. Through the campaign, we champion trauma and equity-informed policies and justice to ensure a healthy, just future for children, families, youth in Virginia. This week, you will have the opportunity to access a variety in the areas of diversity, equity, and inclusion, community-centered engagement, advocacy and activism, policy, equity, and data analysis. We hope that you avail yourself to all of the opportunities available this week and spark your interest and have a fruitful conversation with us. And if you're joining us live, we want you to participate in this conversation. Do a couple things for us right now. Drop in the comment sections, where are you listening from? Are you in Virginia? Are you in Richmond like I am? Are you in another state? What organization that you're affiliated with, if you are, why you're listening today. Click that like, love, or share button right now so that we can get as many people into this conversation as possible. And with that, I'm going to move into our introduction of our wonderful panel of speakers today. And I'm going to start with Fallon Speaker, who is the director of the Family Law Clinic and assistant professor of law legal practice at the University of Richmond School of Law. Prior to joining the law school faculty, Professor Speaker, served as a staff attorney and team leader in the family defense practice at the Bronx Defenders. I'm definitely a fan, where she represented parents in child protective proceedings who were accused of child abuse and neglect. So welcome, Fallon, to today's panel. And next, we have Valerie LaRue. Sorry, Valerie. Valerie is the director of family law at Virginia Poverty Law Center. And she has been a wonderful partner of ours at Voices for Virginia's Children for many years. And we're so excited to have you today and have this really important conversation. So welcome, Valerie. And again, if you are just joining us, remember to hit that like, that share, tell us where you're from, tell us why you are wanting to be a part of this conversation today. It's going to be a really fruitful conversation and have really the opportunity for us to get into a deep conversation. Before we get into that deep conversation, there's a couple of things that we want to make sure you are aware of. One, we had a conversation last year around the same time where we talked about racism in the foster care system that really went into the deep dive of what has happened. We've started at slavery and sort of worked our way through. We weren't able to get into so many of the details, which is what we're going to be doing today. But a colleague of mine will go ahead and post the link to that previous year. So if you want to, you can go back and watch that sort of part one, and then it'll have more context for today. But we still wanted to give a brief history of some racism in the foster care system to get us kicked off into today's topic and what we're going to be talking about. And today we're going to be highlighting a couple of different things. We're going to be talking about marijuana justice within the child welfare system. We're going to be talking about barrier crimes. And then we're also going to be talking about some drug testing that happens within the foster care system. And then we're going to also talk about what is happening right now and today. There's a pandemic that has been happening that has been affecting children and families, and we're still navigating the child welfare system and experiencing incredibly high rates of disproportionality for children of color. So with that, I'm going to kick it off to Fallon, who's going to give us some historical context for the conversation that we're going to have today.
Thanks, Allison. Thank you for that really great and wonderful introduction. I'm so happy to be back here with you guys this week and to have this very important conversation. So as Allison mentioned, we started our conversation about sort of the racialized harm in this country as it relates to the child welfare system last year, and that link is now in the chat for you guys. And so what I really want to pick up in that conversation, just to sort of give you an idea of where we started that conversation, really dated back to the history of slavery, right? Chattel slavery and the removal of Black and brown children from their parents, state intervention, and how that process evolved over time, right, into the modern child welfare system. And I wanted to focus our conversation and sort of ground it on sort of this idea of intersectionality, right? Because I think oftentimes as actors in the system, we think about the work that we do from a very individualistic lens, right? Like we're doing this work in the child welfare system. We don't consider the collateral issues and how these systems have worked together over time to create harm in marginalized communities. And so I want to start grounding us a little bit from that perspective today. And thinking about that, I think it's important for us to consider sort of the history of surveillance and policing, right? Those are two words that I'm going to use. And oftentimes people are like, well, how does that apply in the child welfare system, right? This isn't the criminal legal system. I'm familiar with that term there. But I think if you would ask many people in the child welfare system how that applies today, what they would answer is that the people who are all of us who are actors in the system are acting as a form of surveillance, right? People who are mandated reporters, people who are required to report or acting in some sort of investigatory capacity, and from a policing perspective, right? And if you were asked people who lived in communities such as my clients that I've represented, who is DSS? How do you view DSS? Oftentimes they would say they view them very similarly to the police in their lives, right? As well as the other systems that intersect and interact with DSS. And so I just want to talk a little bit about that sort of surveillance. And so what we know is that in the early 1900s, from an extension of slavery, there was a rise of the idea of surveilling Black and Brown communities. And this was largely to maintain control. Right. What we know is that this idea of surveillance came out of the idea from a period of time of the Ku Klux Klan, which evolved into sort of like this larger ideology that we know as Jim Crow, right? So that we know that there was institutionalized legislation passed, that we know that there were laws instituted to prevent, Black and Brown people from enjoying many of the same rights and privileges as their white counterparts. But not only was this created for that sort of separation, but it also was created as a mechanism of control, right? One, to control property, and this is extending from the idea of slavery, right? That people were property, and land is property, but at this point we're seeking to control land, right? And also to control the ability of Black and Brown people to earn an income. And in some of the legislation that was passed during this time, what we know is that largely welfare legislation was not directed to Black and Brown people. It was created and lobbied for largely by a group of white women for the benefit of single and widowed white women. Right. And it wasn't until later in the 1970s when federal funding started to become more widely available that a lot of these programs asked for funding and were required to incorporate and include a lot of Black and Brown communities. So, what we know is that with the increase of the Jim Crow legislation, this authorized criminal punishment against Black and Brown people for breaking legislation, right? And so we saw a lot of legislation instituted to control, and then a lot of a rise in incarceration of Black and Brown people for failing to abide by that legislation. And we know that those people were then used to work and to provide low cost to free labor, right, for the state and for many of the property owners, similarly to what they had done in the period of slavery, under the guise of punishment through incarceration, right? And so as we see that escalate, what we're getting into now is a ramp up in the 1970s of this idea of targeting a lot of policy, especially from the criminal perspective, on the war on drugs. And I actually was just reading an article and it was talking about how I believe it was June 16th or 17th of, this year was the 50th anniversary of President Nixon announcing the war on drugs, right? So this term was first announced and, coined and credited to the 1970s. We saw the ramp up in the 1980s with the Reagan administration and the crack epidemic. So what we know is that when this ramped up in the 1980s, there was an increase in arrests and convictions in communities of color of people largely based on and out and around the substance of crack, right? And this is largely referred to as the crack cocaine epidemic. During this period of time, it was not just arrest of men, it was arrest of women. We also saw that as a parallel to this, that many Black women were not only arrested, but oftentimes those who were pregnant had their children stripped away from them in the hospital. And even if they were not arrested for use, we saw a large increase in the number of women who were arrested for being associated with people believed to be dealers, right? And so what we saw was the disintegration of the Black and brown family heavily in the 1980s and 1990s, largely around this epidemic and figuring out how to eradicate these substances out of the community. It wasn't in 1994. And it's, the war on drugs is interesting. I'm gonna get to this in a second, because what we know is that this went through decades, right? Like, it wasn't just in the 1970s or the 1980s. This continued. Different presidents, different political administrations continued this war on Black and brown communities. And so what we know was in the 1990s, with the Clinton administration, and largely through the support of current President Biden, there was the violent crime bill, right? And that bill provided grants to increase law enforcement presence in communities of colors, to build new prisons, to push for increased cooperation between police and state agencies as it related to surveying Black and brown communities. Now, what does that mean for the child welfare system? Well, like I said, during this period of time in which there was a ramp up in services, it parallels the drug war, right? Because in the 1970s, initially what we saw was the, introduction of CAPTA, right? So funds to provide increased surveillance for the prevention, detection, and investigation of child maltreatment and abuse, right? In the 1980s, largely proponents of this work in the child welfare system said, hey, we're removing too many kids, we're having too many adoptions, we need to rethink the way in which we're thinking about child welfare. And they did exactly that with the Adoption Assistance and Child Welfare Act. They actually created a program that worked towards reunification. So divesting funds from adoption and fostering children and placing that towards reunification and prevention efforts. This largely flipped around in the 1980s with the heightened increase in surveying and policing Black and brown communities through the war on drugs. And so what we saw was that narrative quickly changed from 1980 to 1992. We need to work on prevention. Prevention efforts aren't working. We're having too many children lingering in the foster care system, where these parents are not quickly recovering from the substances they're using. The prison sentences are too long. We need to think about different permanency options for children. That is the parallel here, right? So while we have the 1994 crime bill, we also have the 1997 ASFA Act, right? The ASFA legislation, right? And what we know with Adoption, Safe Families Act, right, is that it further increased funding, right, to provide for quicker permanency options, right? It created this timeline for parents to abide by, and this federal policy was to boost the speed of permanency through the method of adoption, right? And so now we have this implementation that, parents need to work towards permanency and within the first 15 out of 22 months, right? It codifies sort of these standards as it relates to neglect and abuse and the ability to be able to reunify with your child, right? So largely codifying a lot of language around substance use, around what amounts to neglect as it relates to substance use. It provided incentives for adoption, and then it increased surveillance, right, to detect child abuse and maltreatment. This went hand in hand with the 1994 crime bill. And when we talked about partnering and collaborating with organizations, what we were talking about is partnerships that develop now between local housing authorities, public assistance programs, schools, low-cost medical facilities, places where people who live in marginalized and low-income communities frequent, right? These programs and these resources that they were utilizing now became reporters, right, for child abuse and maltreatment, and partners in this sort of policing effort. We know that not only was there a significant rise in the number of people who were incarcerated, right? So per 100,000 people, right? We know that there was a significant rise, I believe, as it relates to Black people. We saw a rise from like 150 to like like 2,800, right, within a matter of 10 years per 100,000 people. While we know that that was a rise, we also know that there was a rise in terminations as a result of the war on drugs, right? And so in the 20 years from the passage of the 1997 ASFA legislation, we saw over 1 million children being adopted, right? Now, does that mean that 1 million children achieve some great permanency plan? No, because what we also know, because we work in the system, is that a number of these adoptions are what we call broken adoptions, right? And a lot of these children were left homeless, are subject to being in the foster care to prison pipeline, right? And so where does that lead us at now, right? Well, now we're in the middle of another epidemic, largely the opioid epidemic. And we see that the way in which the narrative that we use to describe this epidemic has changed significantly from the narrative that we use to describe the crack epidemic. We don't call children who are born addicted to opioids or in withdrawal opioid babies, right? Like, we don't, as we refer to crack babies, we don't call their mothers opioid addicts, as we refer to women who were pregnant or who were using substances, crack cocaine, crack addicts, right? We don't put them in a bracket of welfare queens. We don't even talk about them in terms of needing punishment, right? We see that the narrative has changed to treatment. We refer to people who are using substances now as people who are experiencing a substance use disorder. Children and families who are involved in that system as people who are, dealing with this disorder and in need of treatment, right? And the way in which we're dealing with it. I mean, there's a lot of, I guess, conjecture about why that is. A lot of that is going to be race related, right? A lot of that is even class related, right? The populations of people who might be infected. But a lot of that is also our recognition of the harm that was done during the crack epidemic, right, to Black and Brown communities. And so I think that in recognizing that some of the harm that we face today is like using how we think about the narratives around substance use, right? And so one of the things that comes up now is that not only are we in this opioid epidemic, but we're also dealing with this surge across the nation of different states and localities decriminalizing marijuana, right? And what does this look like, right? Because what we have seen in some circles in this space in child welfare is people say, okay, well, if a parent is using marijuana, that's not that bad, right? It's not as if it's cocaine. It's not as if it's, some other substance. And I think that narrative can become equally as harmful as the narrative that we created during the crack epidemic, right? That people who somehow use one drug are worse parents or bad parents in a way in which people who use another substance are not. Example, alcohol, right? And how we didn't police that in the same way at that same time, or the use of nicotine, right? And so I think that one of the unique opportunities that we have is to adopt a very much harm reduction model, which we have utilized as it relates to opioid treatment. I think we can adopt that model moving forward for all substances. And I think that and sort of grounding this conversation, one of the ways in which one of the things we want to think about throughout the rest of this conversation is narrative and the language that we use in terms of talking about substance using parents and children who are born with withdrawal symptoms. And then I think the other thing that we want to talk about is like accountability, right? And like, how do we take accountability, right? And like, I think that we as actors in this system today, whatever role you're in, we have to take accountability for what we've done over the past 50 years to Black and Brown communities through this specific targeting of people for substance use, right? And how our actions have directly imploded their communities and their families, right? And I think that and now that we have the recognition that substance use is a medical disorder, how do we provide better resources and prevention and treatment? And then how do we also change our thinking, right? To be in line with the reality that just because someone uses substances doesn't make them a bad parent, doesn't make them a harmful parent, and doesn't necessarily place children at risk, right? And like recognizing the biases as it relates to race and class that go into who we deem are being neglectful or abusive to their children while using substances. So I think those are some great ways for us to think about this as we move into this conversation, sort of the historical context into like where we are today. And the last part that I will add here is that I think this is even more important coming out of 2020, right? And like being in the midst of a global pandemic right now, I think it's even more important for us to think about the harm, right? That we have done and that we can continue to cause if we don't start to correct the root issues, right? Which is largely how we are thinking about these issues and the effects that they have.
Wow, thank you so much, Fallon, for grounding us in so much history, perceptions of child welfare, but also the recognizing of different systems. It's probably one of the most, not, unless you are in the weeds of this work, it's hard to see how so many other systems and decisions make direct impact on children and families. And then what we expect for child welfare to do, pick up all these pieces and fix it. And instead, they're really directed to do a very specific job. So whether you are here because you are an advocate, maybe you're a parent, or you work directly for a local agency or the state agency, it's recognizing this macro system that's impacting our children and families at the end of the day, and how we have to collaborate with so many systems to right these wrongs and recognize. And I think that's one of the beautiful things about what this week is about. It's about racial truth and reconciliation. And we want to talk a lot about, we've just talked about some of the racial truth. And now we're going to talk about, some of the reconciliation. What would that look like? How do we deal with it? So if you're just joining us, thank you for logging on today. This is Modern Racism in the Foster Care System, and we're just getting into the conversation. And we're going to start, and I want to ground our next portion about what happened here in Virginia in the last 18 months, truly. So we've been dealing with all of these things. We've had the COVID-19 pandemic coupled with really, truly racial trauma, but also reckoning in not only our country, but in our state. And that also included the legalization of marijuana and decriminalization, of marijuana in Virginia, and how that's going to impact the child welfare sector. I want to start by saying a couple of things. One, when we think about the pandemic, a lot of us think about economic insecurity. And one of the things that we talked about in large part in our previous talk was about how poverty is often associated with neglect, particularly child neglect. But what we're seeing is a little bit of a differential response in the same way that we just talked about the crack epidemic versus opioid use, where it's sort of been, everyone has been reeling with, regardless of race or social status, reeling with the impact of COVID-19 and how it has played a role in economic insecurity. But do you see how suddenly we are responding differently to families and their needs, where we have stimulus checks, we have the child care tax credit? Not to say that these things aren't wonderful, but we've been advocating for them for decades. And suddenly now that we have a situation where the issue impacts more than just Black and Brown families, we are more eager to do it, we're eager to respond. And in such a short amount of time of economic insecurity for children and families. So I think that's something to recognize and reel with. Why haven't we been as apt to do it? What has been the excuse or the reasoning previously? And then now that we have decriminalized marijuana in Virginia, we haven't addressed how that impacts child welfare. We haven't addressed what we're seeing right now, which are families still receiving punitive impacts within the child welfare system, even though we've made this decriminalization in Virginia. So I want to just start, and whoever would like to jump in first, Fallon or Valerie, I want to make sure our audience knows what's happening right now. If you are a parent and you're experiencing, if you're going through a court hearing and you have a child who is, whether they've been taken or haven't or are still in process, what does that look like for children and families right now in regards to marijuana substance use?
So Valerie, would you like for me to start? Yeah, okay, great. So I think it's helpful to just remind people of the actual legislation, right? And so the legislation is decriminalized. Well, what we know is that there are oftentimes things that it's decriminalized to drink alcohol, right? It is not decriminal. It's not. That does not move into the center of the universe for child welfare, right? Because what we know is that if you are found to be using substances, depending on your age, so if you're a child, right, then you can still be referred to services through the child welfare system. I have observed, in my experience and working in this system, that children have been stepped in for the weekend, right, due to substance use. So the 16, 17-year-old children who are not yet of age, and they've been stepped in meaning held in a juvenile facility as a measure of protecting them, right? I've seen, teenagers who use substances and their parents still be charged with neglect, right, or failure to supervise, right? What we also know is that even after this decriminalization was passed, in terms of that you can, I think it's legal to have a possession of no more than an ounce, right? And there's a certain amount of potted plants you can have in your home. You can be gifted marijuana, those sorts of things. Well, they still have to be out of reach of your children, right? So if you have an open CPS case and they were to come to your home and see marijuana openly within the reach of your children, and that is a very subjective idea of what's within the reach, right? Then you could still be subject to a case in court. And then also, even no matter, and I don't think this is true for every court in the state of Virginia. It has been true for a few courts that I've observed in. When parents come, no matter what the issue is on their petition, they're tested, right? And so, like, what I've seen is that there have been cases come in where substances is not an issue at all, and a person tests positive for marijuana. And now all of a sudden the request is that they take a treatment program, even though it's been decriminalized in the state of Virginia, right? And God forbid anything else shows up, and then it's more severe, even alcohol, right? And so what we are seeing is that people are still being subjected to searches without their consent, and largely not even in cases where substance use is an issue, a child welfare issue, in cases when they're in court, right? Another thing that I've been able to observe is that this legislation has no effect whatsoever in protecting people who have current criminal cases, right? Or who have current cases that are under probationary supervision. What that means is that just because it has been decriminalized doesn't mean that the Office of Probation is saying that this is no longer going to be counted against you if you were to test positive, right? So people are still having to subject themselves to random tests. And if you are a person who is on probation or parole and a person who is the subject of a child welfare proceeding as a parent or a child, then this can be used against you in court, right? Your ability to follow that rule, even though it has been decriminalized. And so I think, we can keep going, right? There's like this doesn't extend to jobs. This doesn't extend to, the eviction process. This doesn't extend to public housing. This doesn't extend to a lot of areas that largely Black and brown and low income marginalized people in Virginia are still subject to in terms of surveillance, right? They're still being surveilled, and these things are still being used against them, and the different systems that are at play, and largely the child welfare system. And I don't have a personal observation about what this has looked like since decriminalization, but what we do know is that largely there is, and we'll talk, I know this is on our agenda to talk about, is that hospitals are testing Black and brown and low income people at much higher rates who are pregnant, right? And this can, while this might not be a cause for removal, what we know, the reason why this is harmful is because it opens up a Pandora's box for there to be an investigation to literally ravage people's lives. And that we also know that this allows room for supervision for some inexplicable amount of time into people's lives. So that's sort of state intervention.
Valerie.
And another thing to know is that, there are judges in Virginia who will automatically test, especially women who are before the court for hearings once their child is removed, and can make it a condition of visitation with their child that they be tested for drugs, including marijuana. And who is harmed by that are children. That directly impacts the child. The child doesn't know why they're not able to visit with their parent. It disrupts the reunification process, and it is really harmful. So we're still using these harmful beliefs against women, against mothers, and it's harming both the mothers and their children. And these kinds of things are just continuing throughout the system. We can't just change one piece. Allison was talking about how all these systems interact. We can't just change one piece and expect that we fix things. We need to look at the whole system.
Okay, and I'm going to go a little out of order here because I'm recognizing that people might be having the same question and need this answer so that we can continue the conversation around, are you saying that it's okay are we saying that it's okay for parents to use these substances, and should they be allowed to parent their children? And we have, I want to acknowledge this question as a social worker, and also for the two of you who will answer this as attorneys as well, what we've seen, but also how we're trained. So as a social worker, we're often trained to go into these situations and respond punitively. It's what we are trained to do. We are told that it's not possible sometimes for children to be raised in these particular homes. And then what we also see for those of you who are in situations where you are the caseworker, and maybe you don't believe, you reject this assumption, but then you go through so many cases where you see the parents are struggling, they don't have housing, they don't make it to their visitation, and then you get worn down. And that's what you bring to the situation when we're having this discussion. That might be what's going through your head as we're talking. So I wanted to acknowledge that. Like, you might say, yeah, that's nice, but what is it like really on the ground? Like, do you know what it's really like to be in the hospital at these babies who are born substance exposed, things like that? And so I wanted to pause there and take a moment to ground us in some data around what does it truly look like for children who are raised in homes like this. And I know, Valerie, you had a lot to say about this, so maybe we can start with you and then we can circle around to everyone to share their few cents. And sorry, we're going a little out of order, but as we were talking and thinking and seeing comments and reacting, I think that it's important to jump here.
Yeah, so, I think what the thing that's important, you raise a really important question, Allison, because I think people do ask that question, like, well, then are we just supposed to leave children, with parents who are having addiction problems? And I think what's important to know is that the science does not support how the child welfare system responds to women with substance use disorders and their infants. And Fallon has already touched on, what happened back in the 80s with, the so-called crack babies. That was actually not a thing. There's no such thing as a crack baby. The science did not, we had this belief that there were all these babies who were, being adversely and lifelong impacted by their exposure in utero to crack, but the science didn't hold that up. And instead, because Black women were more likely to use crack, it fed into this false narrative that Fallon was talking about, that Black mothers are less protective of their children, and that in utero exposure to drugs is a reason to criminalize women and remove their children. And the interesting thing is that, again, as Fallon touched on, that the two drugs for which there is proof that in utero exposure results in lifelong harms to children are tobacco and alcohol. But we don't mandate reporting to CPS for women who use tobacco and alcohol, because these are not as racialized in our society as some of the other drugs. And one of the things that I think is really, to me, one of the tragedies of our child welfare system is that those who are more likely to struggle with substance use disorder are adults who have histories of childhood sexual abuse. And so it is really the height of injustice that we pathologize women who have that history of trauma and then re-traumatize them and inflict trauma on their children by taking their children away. And, as we've already discussed, the opioid epidemic has changed how we think about substance use disorder. We're more likely to call it substance use disorder than to call it substance abuse, which is an act, as opposed to a disease. Because it's mostly impacted white people, we've started catching up with the science, because we have a vested interest in looking at it more scientifically rather than through our lens of prejudice and bias. Fallon touched on the fact that we have, moved to a policy of drug testing mothers when they're pregnant or when they're giving birth in the hospital. And this has been shown to disproportionately affect low-income women more. That low-income and Black and brown women are much more likely to be tested for drugs when they're in the hospital or when they're going through prenatal testing than middle-class white women. And so some people have said, well, then we should just test everybody. Because there's a problem with that, or a few problems with that, actually. One of these is that this is not recommended by ACOG, that's the American College of Obstetricians and Gynecologists, or the American Association of Pediatrics, because the punitive child welfare response to women who test positive is harmful to children. It causes women to avoid help seeking because they're afraid of that punitive response. So they're less likely to seek out prenatal care and less likely to seek out well baby care, and that harms a child. What ACOG's policy is instead is that informed consent must occur during drug screening, and they recommend drug screening, which is very different from testing. So testing means actually testing to see if there's the presence of drugs, where substance use disorder screening screens for, does someone have a problem? And then ACOG recommends that there be a mutual dialogue between the clinician and the woman about what to do about it. Most women who have a substance use disorder are highly motivated during pregnancy to recover from that. Women who can't recover are those who really have a substance use disorder and a physical medical addiction, and that we need to treat that. But instead, we treat it as something to punish women. We don't, even though we have federal laws that mandate spending on substance use treatment for women and prioritize women who are pregnant, we don't actually, very few states have sufficient treatment programs for women who are pregnant or prioritize women who are pregnant. The best way for us to minimize the harm of parents who have substance use disorder is, first of all, to recognize that mothers and their babies belong together and recover best together. So for instance, with newborn abstinence syndrome, which is when children are born with an addiction and are then withdraw at birth, those infants are most recover best when they have skin to contact with their mother. They have a need to attach to their mother. They recognize their mother's voice and their heartbeat, which they heard in the womb. And so they recover best when they are connected to their mother. And women are more likely to recover when they're able to focus on their child and their love for their child, and that attachment that they're developing with their child. So when we remove children from mothers, we harm both the mothers and their ability to recover and the infant. The other thing that I've noticed in the child welfare system is a prejudice against medically assisted treatment. That's things like methadone. That's the standard of care for pregnant women. It is actually best for the fetus for the mother to have that medically assisted treatment. It reduces fluctuations in blood levels of opioids. It reduces fetal stress. It is associated with a decrease in intrauterine fetal demise and a decrease in preterm delivery. It also is associated with a decrease in maternal deaths and other problems that women can have during pregnancy and postpartum. So the fact that in our child welfare system, we are prejudiced against women who use what is medically considered the standard of care for treatment shows a mismatch in the child welfare system with the science that shows what's best for children. What should we be doing? We should be talking to these moms and engaging them in what they need and what they want to be safe. If women are in treatment, we know that treatment includes relapse. That is part of the treatment and recovery process. So how do we help moms develop a plan for when they relapse? What are they going to do when they relapse? So are they going to reach out to family? Do they have a plan so that their infant will be safe during relapse? So if we look at it from a harm reduction standpoint and realizing that removing children is one of the harms, we need to figure out how to help mothers and fathers, but this especially applies to mothers because we treat them more punitively than we do fathers. How do we help mothers to come up with their own plan of safe care so that the child can remain with the mom can get the substance use treatment that she needs, and the mom can come up with a plan for what happens if she relapses. If we have these kinds of safety plans in place, then children can remain with parents who have a substance use disorder during the recovery process. And then we also need to recognize that women are using drugs as a way to self-medicate for issues that we often as a society cause to them. And that includes sexual abuse, it includes misogyny, it includes racism. And we need to help women to recover from that trauma and not inflict additional trauma on them and their children in the guise of saving children from their parents. One of my favorite quotes is, "There's no such thing as a baby. If you just set out to describe a baby, you will find you are describing a baby and someone. A baby cannot exist alone, but is essentially part of a relationship." And that dyad, the mother and child dyad that we have been disturbing for centuries, as Fallon mentioned, is something that we need to treat with a lot more respect and honor, and especially for Black and brown women who have not been accorded that kind of respect when it comes to being a mother.
And I just add one thing there, Valerie, because I think you did a really, really great job of explaining this, is in my observation through the clinic, our students oftentimes do these Know Your Rights campaigns. And, last year they went to several substance use programs, right? And now I've worked in multiple jurisdictions, North Carolina, New York, and here in Virginia. And at those programs, they sought, right, to teach people who have substance use disorder ways in which they could manage and create safe plans for their children, right? Some who, maybe were expecting children, some who had children who were already involved in the system, and ways in which they can think about it. And while the response overwhelmingly was positive from the programs, there were some programs who were like, don't do that. We actually don't want you talking to our program participants. We only practice zero abstinence. If they were to tell us they were going to use, if they were to tell us they were thinking about using, that would be a subject for us to report to child welfare, right? And to CPS, and that is, to us, is an indicator that they cannot be a good parent. These are things that were said. I think one of the presentations was stopped and we were asked to leave. These are things that were said, that this would be an indicator that this person is not ready to parent, an indicator they're not a good parent. And so, and you know, this is coming from directors, people who have presented at you know, large, and a couple of the directors told me that they were largely involved with a lot of child abuse prevention programs here in Virginia, right? And this is what the teaching has been for years. And like, you know, the information that I was sharing actually was not, you know, information that they wanted their participants to see. Even when I offered to show the data, even when I offered to connect them with the people who were disproving these myths from 20, 30, 40 years ago, right? And so I think that when I am talking about our role, this is our role. Our role is to challenge that, right? Our role is to not continue to send people to programs that continue to be in this very outdated method of how we are going to address this issue, right? Not to continue to partner and to support those sorts of programs. And I think me and Valerie both mentioned the term harm reduction, but I'm not sure if everyone is really fully understands the principles of harm reduction, right? And so I am not an expert in any way, shape, form, or fashion, and we can share some resources on, you know, organizations that are doing this work that you could follow up on, and people who are actual experts in this field. But just to include you guys on some of the ideas, right? It's really, and this is just reading directly from a site that talks about harm reduction, harmreduction.org. And it states that it incorporates a spectrum of strategies that includes safer use, managed use, abstinence, meeting people who use drugs where they're at, and addressing conditions of use along with the use itself. You know, because harm reduction demands that interventions and policies designed to serve people who use drugs reflect specific individual and community needs, there is no universal definition or formula for implementing harm reduction. And I think that what we're talking about here is that for years, we have implemented a universal approach to how we're going to treat people who are found to use substances and have children. And I think we need to rethink that, right? And the harm reduction model provides us with an opportunity to think about this, not only from the individual perspective of what's best for the child, but what's best for the parent, what's best for the family, and what's best for the community, right? And I think we can learn a lot from adopting those sorts of principles.
One thing that I was really encouraged by is hearing the Senate hearings on the reauthorization of the Child Abuse Prevention and Treatment Act, which was one of the drivers of all this testing and punitive treatment of mothers. And Senator Burr, who's a Republican senator, said in introducing the bill, we are bringing a different approach to infants affected by substance use disorder. This issue has been viewed as child abuse rather than an issue of addiction. We are clearly stating that the purpose of plans of safe care is to bring a public health response to infants and their mothers, and to support the health and well-being of the infant and mom rather than penalizing the family. So there is finally this recognition of the harm that we've been inflicting on families. But again, it's because of the opioid epidemic and how that has affected different families that has made people finally sit up and take notice to this issue. And you know, I'm glad that perhaps this will then really start sort of changing that ship. But we also know that when resources are scarce, that we're going to implement these policies in disparate ways. And that's one of the things we really need to watch out for.
This conversation, I'm sure everyone watching, has been so fruitful, because one of the common questions we just talked about how many folks really understand that data. But then the other part of it is, okay, armed with that information, are people ready and willing to change the way they do business as usual? And so we've talked already about some of the recommendations, but just want to highlight them. Number one, we really need to focus on banning testing in child welfare cases. We see that it really doesn't do anything to harm reduction for that child's safety right there. But what it does is potentially have that child removed from that home, which we know is trauma in itself. One of the things that we try to continue to talk about over and over again is simply removal for a child, whether that family was unstable or not, is an ACE or an adverse childhood experience. And that's one of the other reasons we highlight kinship care oftentimes when we're talking about these situations. that become unavoidable for folks who are, putting in the comments or thinking in their head about, well, what happens when the situation is unavoidable, or that parent needs to go into treatment? How do we have a safety plan for that child? And one of the best things that you can do is create a safety plan, and in fact, have a FAP meeting where a kinship care provider is in that situation, is part of that person's team, because what we know about kinship care is that child is more likely to be reunified with their family of origin. And we also know that if that parent were to relapse, which is part of recovery, that kinship care provider is more likely to be able to step in temporarily, help stabilize the situation, and then have that child continue to have visitation and reunify again once that person is through their immediate needs. So those are some of the things that we need to have in place and intervene. But we also want to look at the 2022 legislative session and addressing what is happening right now in the child welfare sector when it comes to testing. And it's crazy because time is moving so quickly. So when I want to get into what we have all known for a long time about the child welfare sector, but we don't talk about it as often, is that testing in hospitals for moms postnatal, so right after they give birth. And I can just set the stage here. If you're in Richmond, people who use substances often know which hospitals to give birth in versus other hospitals. They know certain hospitals, ones that are closer inner city, tend to do that automatic testing. I think in an effort to try to quickly put safety plans in place, but often what we just talked about doesn't really do the harm reduction that we're trying to do. And instead, they'll sometimes avoid prenatal care to begin with, which is harmful to themselves and to the child long term. But we also know that they'll sometimes go to a different hospital in order to avoid that testing to begin with. So I'm going to toss it over to Valerie to talk about the practice of testing in hospital providers and what we can do as a system, not just child welfare, to shift that practice.
Yeah, so the American College of Obstetrics and Gynecologists really does not recommend drug testing women at all, because first of all, it's not a very useful tool. It shows the presence of some substance in that moment. It doesn't say anything about whether the woman has a substance use disorder, whether she just happened to recreationally use, if it's a real problem that's ongoing. It can catch opioids that the woman is using pursuant to a prescription for actual pain and issues that she has. So it's not really a useful tool for determining, is any intervention called for at all. And instead, they recommend that during the pregnancy, that providers work with the woman to determine what are her health issues overall, and how do we mitigate those health issues while she's pregnant, during the pregnancy, during birth, and after birth. And this is much more useful for keeping children safe and healthy. We know that women of color, and especially Black women, are much more likely to be at risk themselves for health issues and mortality when they're pregnant. And so putting policies in place that prevent women or discourage them from seeking healthcare while pregnant is just the worst thing that we can possibly do. Instead, what we need to do is determine where people are, where are they, and how do we help them to get to where they want to be. And that's what we need to be doing rather than testing. Drug testing is much more likely to be used in certain hospitals that tend to be in Black and Brown communities, and also more likely to be used on women who have public health care rather than private health insurance. And so but it doesn't, again, it doesn't make a difference if we say, oh, well, then we should drug test everybody, because again, that's not useful data. So instead, let's do what's called screening, which is asking a series of questions, and designed to figure out what a woman needs and what her child will need. And if we're able to do that in our hospitals, and if we recognize that this is not child abuse or neglect, and so therefore this should not be a mandated report. It's really interesting to me that the law actually says that only Virginia law, only children who are born affected by substance exposure need to be subject of a mandated report. So simple testing doesn't show any effect to the infants at all. It just shows whether there was some substance present in the woman at that given moment in time. It doesn't show that there's actually any effect on the infant. And so far, as I mentioned earlier, the only things that have really been shown to have a deleterious effect are alcohol and tobacco. We all know about fetal alcohol syndrome disorders. But tobacco actually has more long-lasting effect on children and throughout their lives than other substances that we have a moral prejudice against. So that's what we need to be doing. We need to be sitting down with women, talk to them, figure out what they need, helping them to develop their plans of safe care, like you were just talking about, with them, giving them actual substance use treatment that includes dyadic care. It's interesting that federal law allows states to use Title IV-E or foster care money for dyadic substance abuse treatment. That's substance abuse treatment where the woman is inpatient with her infant or child. But so far, Virginia is not spending any of our federal money on those, even though there are a few of those treatment centers in Virginia. We haven't certified them, even though most of them meet the standards of the federal law. So we're not putting our money where our mouth is. We're not doing the things that we should be doing and that we know work. And instead, we resort to things that are simple like testing. And a lot of that testing, as Fallon has mentioned, is not with consent, and medical procedures should never be done without consent. So we need to make sure that if women are subject to testing, that it's through consent. But it's much better to have a conversation with a woman about what her needs are in a non-punitive atmosphere that can help the woman get the help she needs, and to help her develop the kinds of harm reduction strategies, including plans of safe care for that mother and her infant, rather than removing the child or being punitive.
Thanks, Valerie. I think two things I want to highlight being, I know that there are several of you watching from all over the country in different states. One, a couple of things. Fallon dropped some links that we will share in the chat. My colleagues will get in the chat for us so that you can take a second to review. But if you have a dyadic care in your state and it's working really well, if you could post those links in the chat so that folks who are watching from other states can click on it and see what you're doing. I know there's a really excellent program in Baltimore where they've really engaged and are using federal dollars to provide more dyadic care in their city. So what did that look like? What was the process? But I think that's an opportunity, and oftentimes federal dollars left on the table that we need to engage and use, and something that the group that we're talking, the three of us will be working in Virginia to try to ensure that we do utilize those federal dollars. Sometimes it takes a state match, sometimes it takes some investment dollars for those organizations that are in other states to come into your state, or for us, Virginia, to be able to open up those facilities for families that are so desperately needed. And then we may have to explore, what does no testing on mothers look like in your state? How can you make that state law? But then the other portion of that, how does that impact all of those other systems? What will it look like for families to receive referrals for services when they haven't necessarily received a testing, but they have screened and have risk factors? We now have Family First, which is we're able to serve those families who are at risk for entering the foster care system, and we can serve them in new and unique ways. We don't have to wait for that positive test to provide them the services that they need. And I think that's what we're trying to drill in today and talk about. And Fallon, I think you wanted to share as well.
Yeah, so sorry, I always have the other side of this equation, right? Which is that a lot of medical professionals are actually denouncing the screening tools that are used currently, right? I work with a number of experts, from child abuse experts, or, to orthopedic surgeons, to child abuse pediatricians, to social workers who are doing these screenings in hospitals working with pregnant women. And oftentimes they would say to me, like, well, the reality is sometimes we have forms that we only give to certain parents. We don't even have these in clinics for all of our patients, right? Because we don't think all of our patients are going to check off the boxes. And yes, we ask the things that are racist and classist, right? And that, like, as soon as someone checks a box that says, yes, I'm a victim of, I've been abused before, physically abused before. Yes, my partner has emotionally abused me. Yes, I have used marijuana in the past 6 months, or yes, I have used, this in the past 6 months, or whatever. As soon as they check that box, well, now we're creating a report, right? And we're creating a call. And, like, the reality of what I'm trying to say is that that's not helpful. They recognized it too. That's not helpful, actually. That's policing people. And nothing about that intention is coming from a place of, I want to provide you with a resource or help, because nothing about checking those boxes suggests that that person is currently in need of services, right? Like, that's the reality that I think that is going to wake a lot of us up, is that, like, recognizing that people can be going through these things that we have been trained to think are in need of services and not be in need of services, right? Like, maybe that isn't the actual thing that they are in need of, right? The resource that they are in need of. And in fact, that the resource that they could possibly be in need of is something completely different. And so that is one thing I just wanted to highlight. And I think that, if
That's
you guys,
a really good point. Yeah.
If you want to think about a jurisdiction that has made this leap, and, I work with a group of organizers and policy coalitions in New York right before I left in 2018 and 2019, who were thinking about, we had already reached out on a local level and said, hey, we need to stop drug testing across New York City in public hospitals. It was to a point where I literally was cross-examining DSS on the stand, and they were saying, it's our policy, it's an internal policy to ask that every Black and brown mom is tested, right? That's the internal policy. When we go to the hospital, we ask the social workers, did you guys perform a test? And it's not just a test on the baby, but a test on the mom as well. That was brought out, right? And so, and I believe in 2019, 2020, those coalitions were actually able to successfully lobby to end that practice in New York, right? And then I would say the other thing that came about because of that is that what we will often see is, even though it had been decriminalized, right? Marijuana has been decriminalized, is that even though what happened was the department said, okay, we're no longer going to use marijuana use as a reason to remove a child, right? Substance use in general, no longer just a necessary reason. But now we're going to say that if you use substances and you fail to comply with doing a program, or now it opens up the door for us to investigate other things and to continue to survey you, right? And so that became the problem. And I think it's also recognizing that, right? Whether continued presence by the state is what is going to be a solution to any sort of impending harm or risk to the child that we see, right? And, like, whether or not that is actually a proper solution. And I guess the last thing I wanted to mention about this, because like I said, I think you had done such a great job talking about this, is thinking about the delay and the adverse harm that this can have, right? So over testing and surveying people who are using substances and how that creates more harm, right? Because all of the studies show, Dr. Roberts has done so much great work on talking about this, about how women and families in general who live in systems or communities that are heavily surveyed by the Department of Social Services are less likely to go to the Department of Social Services for aid, right? That is just a reality. And so then when that extension of that, because they see them as a policing force, when that extension of policing goes to their medical provider, to their therapist, right, to their child's medical provider, to their child's school, they no longer see these places as resources or places of support, and they no longer seek out help there. And so what we're doing is eradicating that support network that many of these people have come to lean on, right? Because now we're requiring them to have this police power as well. And so I think that when we're talking about providing resources, we have to recognize where we're also eradicating resources at and how we can strengthen those resources for families.
And that is a really, really good point. And it brings me to another issue that just drives me crazy about the child welfare system. And that is that we actually bring, we don't look at it from a child harm perspective. When children are removed from parents, we don't say, what will it take for this home to be safe for the child to be returned to? Instead, we say, does this parent deserve to have their child back? And every time we hear something like, oh, well, she didn't complete the program, and that's why her child can't return, we don't say, well, did not completing the program mean that somehow her home is now less safe? Or does it mean that we're just holding it against her that she didn't complete the program? So if we say, oh, she, failed to go to, she went to 10 of the 15 sessions of drug counseling or whatever it is. And so therefore, we're not recommending that the child be returned to her because she missed 5 of these sessions. That has nothing to do with whether the home is safe. And we are not looking at it that way. We're not saying, is the home safe now? Is the mom safe now? We're saying, does the mom deserve to have her child returned? And that is not the standard. That's not the standard under the law. And it should not be how we treat children. We should not be treating children as pawns or tokens or rewards. We should be treating them as human beings who belong with their mother, because that is what leads to the best child development. Children develop best when they are with the people that they're attached to. We don't understand in our society what attachment means. And whenever I hear a social worker say, oh, well, they can't have a visitation with their mom because it'll disrupt the attachment that the child is forming with the foster family. Children can attach to multiple people, but it harms them to be away from the people that they're attached to. And so when we treat children as some kind of pawn or a reward to the parent for their good behavior, instead of as looking at it from the best interest of the child, which are to be with the parent that they're attached to, we're harming them. And so, yes, when we use those kinds of drug treatment programs as part of our reward and punishment system for mothers with their children as the reward or the punishment, we're not helping children.
And everything you all said, and I'm glad that one of my favorite things about this group is that we can discuss with each other, we can disagree, we can talk about what the best practices are, and that's what we want for you all who are watching, to be able to have these discussions, whether it's in your locality, on the state level, or in your particular state outside of Virginia, is to have these thoughtful conversations, talk about what the best practice is, disagree a little bit, and come together so that you can change your child welfare system to dismantle these issues of racism that still persist today. That's what's really important. And the final note that I wanted for us to talk about before we move into some questions, and if you have questions or thoughts or comments, please be putting them in the chat. Our organizations and our colleagues are responding to them. The 3 of us will go back and respond to them as well. But we want to also address and acknowledge the barrier crime statute that exists currently in Virginia when it comes to individuals trying to become foster parents. We have data, and we know that in Virginia, Black children disproportionately are disproportionately represented in the foster care system. But on the other side of that, we also know that when we break it down and look at who are our families who are currently fostering, we know that the majority of our families are white, and very few localities have enough families of color to place children into homes that look like them or have the same cultures as them. And this is not to say that white families can't be foster parents. That's not what we're saying at all. But what we're saying, why is that? Is the question. So why is that is really wrapped up into these barrier crime statutes. We have, there are federal laws that, of course, each state is beholden to around who can be a foster parent, and certain criminal acts that they could not have committed in order to qualify to become a foster parent. That is to protect the child, of course. In Virginia, we have gone far beyond that barrier crime statute, and it actually, part of it is wrapped up into what we've been talking about today, which is really around substance use and having criminal convictions. Some of them are around what we just talked about today around the I cannot get this word out today, the decriminalization of marijuana, but then how that has been impacted in our barrier crime statute, and how many years we have some folks in Virginia who have applied to become foster parents, and they have a misdemeanor criminal offense that happened 10 years ago, but they're still not eligible to be a foster parent. And we know that because families of color, and especially Black families, were disproportionately impacted by our war on drugs, quote unquote, that they're more likely to have those criminal convictions than our white counterparts, and therefore ineligible to become a foster parent. I'll go directly into the recommendations around that, as we really need to just simply repeal these barrier crime statutes that go beyond the federal requirements. We know that it is directly in response. It will hopefully increase the number of families who are eligible to become foster parents. But even beyond that, we have a lot of families who have been kinship providers. And the reason that they didn't go down the path of becoming a licensed foster home for their niece, nephew, grandchild is because of these barrier crimes. So it's okay for them to be diverted into kinship care and to go and live with that family member, but it's not okay for them to become a licensed foster parent. That just doesn't make any sense. All it does is it reduces the amount of financial assistance that that family might receive, and it reduces the amount of oversight that family may have and actually may need, depending on that family's different circumstances. Every family doesn't need that level of services, but some really do need the coordination service. They need the caseworker to help them get that child enrolled into school, figure out how to get the child on Medicaid, all of those things. But what we're seeing is you need to do it in an informal way and not through this formal path because of this barrier crime statute. So the wonderful thing is the state and many localities are highly in support of this repeal, but we need to effectively inform all of our legislators about the need for that change. And it's something that we need to take direct action on in the 2022 legislative session. But it's also for anyone who's watching from another state, take a look at your barrier crime list. You may not even have realized that this is a reason why you have such low numbers of families of color who are your foster parents. I'm of course not saying that is the only reason that families of color aren't fostering, but it is one of the reasons. And we don't have hard facts data, because what happens is a caseworker may say, if you have that in your background, don't even bother applying because you're going to get rejected. It's not worth the effort. And that simply doesn't make any sense. So, go ahead.
I just wanted to add to that is what I was talking about earlier when I was talking about family disintegration, and sort of like the way in which Dorothy Roberts, or Professor Dorothy Roberts, has coined that phrase. And really what it's talking about is that when we have generations of people who have been targeted by the system, either the criminal justice system or the child welfare system, or really play into any of these systems, right? Housing system, immigration system, we create records on people, right? And then we use those records and utilize them in some places. For example, in New York, at one point, it was that these records could remain on file for 20 years after, or like 10 years after your child's 18th birthday, so up until your child was 28 years old. But what we know is that not only do these records prevent you from becoming licensed foster parents, they can prevent you from becoming a kinship caregiver, right? So like, from being a diversionary resource and a safety plan, you can no longer be a placement resource in a safety plan meeting. It also prevents, and I think this is getting a little bit deeper into this, it prevents people from getting employment, right? And so or for working on different areas with children, right? And so a lot of the jobs that are easily accessible to people living in marginalized communities, which would allow them to come out of this cycle of continued poverty, right, are no longer accessible to them because of these records, right? And these aren't records that are just created from the criminal legal system, but also records that we create in the child welfare system, and sometimes that are created without even coming to court, right? Like without even having any sort of judicial oversight. And so I think that, I think it is important for us to consider the sort of barrier crime statutes, but I also think it is important for us to consider our policy that we are utilizing to decide to make cases founded, and what we use to decide who can be a resource to families and who cannot be a resource to families. And I think ultimately it is something that we should consider when we're talking about young adults and the types of cases that we are charging people with when we're alleging abuse and we're alleging neglect, and the sort of impact that could have on the family ultimately long term, not just in the short term.
Valerie, do you have anything else to add before we go into our Q&A? Okay. This has been such a fruitful conversation, and I hope that you have gained some knowledge through it. I know that we have people watching on different platforms, so maybe you're on Facebook or on your own YouTube. A couple of things that I definitely want you to do is, if you haven't already, hit the like, hit the share button, so that as many people as possible can come back and watch this later, or maybe you're just joining us, but we've been talking a lot today about modern racism in the foster care system. And so one of the questions that someone has submitted is around so if you're a local worker and so much of what is happening is out of your control, what advice do we have for them to help reduce this harm reduction, as we've been talking about, for them to be able to do right now while they're awaiting the things that need to happen on the state level as far as code changes?
No, that's a really good question. And I hear from social workers a lot of times, well, I see these things and I understand these things, but my, agency mandates X, Y, and Z. But I do think it's important to know that, even though an infant, may be reported to the department, it doesn't mandate an investigation. Instead, Virginia has 2 different levels of response, and one of those is what's called an assessment, and the other is an investigation. So unless there's some other reason to believe that the child is unsafe, if a social worker is responding to that report, all they need to do is an assessment. And the assessment means making a referral to substance abuse treatment and coming up with a plan of safe care. And that's where your opportunity to understand what harm reduction is and come up with a harm reduction plan with the mom and the family. That includes, as you mentioned, Allison, other family members that can be available as a support for the family, rather than an investigation that leads to removal. An assessment means that the family can refuse services. And that's another thing that I think that social workers need to be looking at, is when a family refuses services, some of these social workers will say, okay, well, then we're going to switch to an investigation. If a family refuses services, unless there are other reasons to believe that the child is unsafe, then you need to close the case. And I think as more people understand this, as you are training social workers, Allison, I'm very glad that you're there. The more that we can start helping families stay together rather than viewing everything as a reason for intervention.
I second that. And I would also add that one of the things that Valerie had mentioned earlier, sort of I think was like dyadic work, but I think that in my work, even here in Virginia, like I said, this is going to vary. And I know we have people tuning in from all over. This is going to vary depending on what state you're in, right? When I was for example, in New York, there was not a lot of opportunity for people to have what we call supportive housing, right? Meaning that if we felt that the person had a intellectual disability or suffering from some sort of mental health issue or substance use disorder, that we could prevent removal by allowing them to be in a housing situation where they will receive support, right? What we recognized was that largely most of the clients were homeless, and so like when these issues came up, if they were homeless and there was no other family to assist, then the child was diverted into foster care. it was a well-known problem. And I gotta tell you, New York City was very much more resourced than Virginia, largely, right? There's a lot of resources there, and it was still a problem. The wait lists were years long. People were on those wait lists for years. Well, and talking to, program leaders and organizations here in just the Richmond area of Virginia, what I found is that those programs are also few and hard to come by, right? They don't really exist. And what we know, and what in talking to these professionals, what they say is, yeah, this could be this could be great, right? If we had placements where we could send people with their children and provide them support and, ensure that they were getting the treatment that they needed to receive without being separated, we would absolutely take advantage of it. We would absolutely recommend it. We just don't have it. Right. So there's one part of it. And then the second part of it is, even when those spaces are available, people don't know about it thoroughly, that people in court are not recommending that. So the Department of Social Services isn't recommending that people who are representing parents and children aren't representing to the court that this is an option. Right. And so in addition to, I think, providing more resources for opportunities like this, I think we have to educate ourselves about other alternatives, right? To remove alternatives to sort of placement and care as well.
Thank you both. And another question, and this will have to be our last one because I can't believe we're out of time and a few more things. And so please don't stop putting your questions in the chat, because we will go back and answer those. We'll post links and I'll jump on right after and answer questions from folks, and you can always reach out to us as well. But folks are curious where they should go to get, you did some of the historical context. Do you have advice on where they can go to get more of this if they're newer to the field, or if they've been in the field a long time and just don't have this historical context? Where can they learn more about this information?
Professor Roberts' book, the book that Fallon speaker just referenced earlier, is a really good place to start. And there are, you can see videos of her speaking about this. If you're not a reader, you can find her books, find things she's written online. That's a really good place to start.
Absolutely. So one of those books is called Shattered Bonds, and others called Killing the Black Body. I'm also happy to share with you guys a list of resources for people who are thinking about this work differently. I think if you're here in Virginia and you want to think about intersectionally how some of these issues, how to work on these issues from an intersectional perspective, well, there are not a lot of places that are doing that. I got to be honest with you, right? But there are organizations that are starting to recognize these issues. One particular organization is Marijuana Justice. And so they have done so much work in taking the lead and sort of working towards decriminalization. And but I've actually been working with them and been called in to consult with how can we think about these other collateral issues, right? And like how this is coming up in other spaces outside of the criminal legal system. And so I think that's an opportunity there. I think also inserting these conversations about the intersection into the spaces that you're already in, and bringing in people who are experts and who have the experience and dealing with it across the board, not to my own horn, but to like sort of lead these conversations and think about ways to start to move the conversation forward. There's a national organization, Movement for Family Power, that's doing a lot of work in disrupting these spaces and starting to change these narratives. So that's a great organization to follow. And then I'll also place some links in the chat and share with you guys so that you can I'll put it here so you can look at it and see some more resources and national organizations that are starting to think about how do we change these narratives moving forward.
Yeah, and for professionals, the Family Justice Initiative is another good place to start.
And I was also going to add another national organization is UPEND, UPEND. And they actually have a conference that they're planning. Oh, I forgot the dates. I think they're in October, but I'll have a colleague drop that link in the chat. That'll be a great place to start. It might be like require all of your staff to attend that conference. They really talk about completely ending the child welfare system, like what that would look like, and be some fruitful conversations for you all to have afterwards, have those conversations, of course, here in the chat. But I wanted to do a couple of things before we conclude today. One, I want to invite you to continue to attend the rest of this week's events for Racial Truth and Reconciliation Week. I'll have a colleague, again, I'm keep asking colleagues to post links in the chat to the rest of the events for the week. There are going to be some continuing great conversations. Also, if you want to be involved in our foster care policy work, please reach out to me directly. We have a foster care policy network that we invite people to serve on, where we create a unified legislative agenda where we're going to be addressing many of the issues that we discussed today. So please reach out to me to be involved in those initiatives. But also, if you're interested in anything around advocacy or an engagement, or maybe you've experienced this personally and you want to share that story with maybe a legislator, or you want to be a part of the conversation, you can reach out to our advocacy and engagement manager, Kristen Lennox, who can get you plugged in and walk you through that legislative process and the advocacy process that might seem scary and daunting, but we promise you it isn't, and your stories are valuable. Your voice can be the difference between getting these things to the finish line and not. So I encourage you, if you're in that situation, to please reach out, and we would love to work with you. The last thing that I want to do today is acknowledge the depth of this work and acknowledge how difficult it can be to have these conversations. It can be difficult to feel like we talk about it, but don't do a lot about it. It can build up in our physical body. It can leave us stressed. It can leave us weary, exhausted. Maybe you're feeling all of those things. Maybe you're reeling with all of the things that are happening in the world that impact this, and feeling like maybe feelings of hopelessness, sadness. And it's important to acknowledge those feelings and to work with them, work through them and talk about them, so that we can do some of this work, but also know when we need to take a step back to take care of ourselves. So I'm going to actually lead us through a very short activity to let go of some of the things that we talked about today, and I hope that you'll join me. I'm not going to turn my lights off because then you won't be able to see me, but if you're watching this from your office or maybe from your home, I encourage you to either dim the lights or turn the lights so that you can just really focus on my voice and our breathing while we do this exercise. So I'm going to ask you to join me, and I probably won't, so I'm watching, but to join me in closing your eyes. And we're going to focus on our breath. And it might, if you want to, you can put your hand on your chest so that you can start to just feel your body breathing. You can feel your breath. I'm going to ask you, so we're going to take a 5-count breath, and we're going to take a deep inhale in. 1, 2, 3, 4, 5. You're going to hold that for just a few moments, and you're going to exhale. 1, 2, 3, 4, 5, and just kind of continue that breath. We're going to start with relaxing our toes. Feel the energy in your toes and just wiggle them around. Relax your toes. Move your ankles around and move your ankles. Release any tension that are in your calves. Might take some breaths to relieve that tension, moving up to your thighs and feeling any tension in your body, breathing it out. Let's move into our stomach. Might take a deep breath in and deep breath out, and just relax your body. Moving into our chest, and relaxing and relieving any tension there. Let's move into our shoulders, move our shoulders back and release some tension there. Move into our arms, feel your arms and release that tension. And your hands, wiggle your fingers around and release your tension there. Move into your neck. You might need to swallow or breathe to release the tension in your neck. In your face, just relax your face, relax the muscles in your face. And your head, relax the muscles in your head and just breathe. And we're gonna do some more deep breathing. We're gonna take a big inhale, and we're gonna hold that for just a moment, and then we're gonna blow really hard out. And just relax, make sure our whole body is relaxed. We're going to acknowledge the things that we heard today that may have made us feel stressed. acknowledge what control we have over it, and we're going to blow and release it. And know that in any time you are feeling overwhelmed or anxious, you can always come back to this moment and recenter yourself with your breath, and relax and relieve some tension. And you may have a faith you can call to, whatever faith you are in, to help you through this moment, or you may need, or you can use other tools, and using some affirmations. So today I'll use some affirmations, and I will start with I am, because we are, and I'm using a little bit of a different proverb there. There are lots of different people use them, but basically meaning that we are all together in this. We are a village, we are taking care of each other, and we want right now in this moment to rest. So with that, we can slowly open our eyes back open. Maybe you can turn your light back on, or you can just stay in this moment. But thank you so much for joining us today. I hope you learned a lot, you relaxed a little bit towards the end, and we invite you again to join us for the rest of Rachel